Ready. Oh, yeah, you're there. I just couldn't see you on the screen. Um, we'll go ahead and get started. So you have plenty of time for your talk because I know you have a lot of great things to share with us.
Yeah,
So welcome everyone to Geriatric Medicine Grand Rounds. Our speaker today, again, as is tradition at the end of the year, is one of our four geriatric medicine fellows, Dr. Christopher Nguyen. And he's going to talk to us about osteopathy and geriatric medicine, which is something all of us need to learn more about. I'm very excited for your talk. So you can go ahead and get started, but I'll ask them that before you get started, since you will be graduating in just a couple weeks and moving on, if you could tell everyone what you're headed to next.
of course. Thank you for the lovely introduction, Kate. Yeah, so good morning, everyone. Thank you for joining in for my grand rounds. I'm Christopher Nguyen. I'm a DO. My pronouns are he, him. I'm one of the last geriatric fellows to present. And so upcoming in early July, I'll be moving over to Las Vegas, where my original residency was, to start a job with Intermountain Healthcare, running a primary care clinic for Medicare Advantage 65 and older, and starting out there from the beginning. So I'm very excited. And so again, thank you for everyone joining in today. So this subject to me, I'm very close to, and quite frankly, I appreciate the help I had from Dr. Kay Ritchie and also from Dr. Kate Bennett, especially in trying to have all these ideas I have about this topic and trying to consolidate into like a single hour as well. And so I wanted to talk about my profession, osteopathy, and how I apply it into geriatric medicine. So I have a couple outlines. I have an outline of a couple things I like to sort of just like run through, which is, of course, introducing it from the fundamentals, a brief overlook at the history, what are core principles and what constitutes our philosophy. Generally, what I'm thinking about when I'm looking at an older adult as opposed to like a younger adult, when we're applying osteopathic principles. And then honestly, for me, I like to go into the fundamentals of like palpation and the things that I look for my physical exam that I hope that even with MDs that you can learn and put into practice as well, OMT, and then overall ending on with like this overlap in some of the philosophies as well. So briefly, hopefully, what is osteopathy? So term was coined like in 1885, osteo coming from bone, and then pathia coming from the concept of like suffering, disease, or feeling. And so when we put together, it's like the disease state that comes from the musculoskeletal structure. And essentially, osteopathy is about the medicine that emphasizes manipulation of your muscle tissues and your bones in order to like promote health. A.T. Stills, coming from the 19th century, our founder, he had a lot of very verbose ways that typically people from the 19th century speak. But the best summary I found was a scientific knowledge of anatomy and physiology in the hands of a person of intelligence and skill, essentially a practitioner, a doctor, who can apply that knowledge to use of man when sick or wounded by strains, shocks, falls, or mechanical derangement or injury of any kind to the body. Let's see. So I use a handful of shortcuts here. So of course, one of them is DO, that we always put the end of our names, and that's for the Doctor of Osteopathic Medicine. A handful of phrases that I will throw around is either OMM, OMT, and sometimes manipulation as well. So OMM, I like to call it osteopathy, but when we talk about the modern practice of medical care by other DOs in the United States, which is like medication and OMT combined together, we typically just call it osteopathic manipulative medicine. So overall, we call the field would be like OMM. Though like I know a lot of traditional people who prefer osteopathy because it sort of connects you to like its history, and also of other physicians or other practitioners around the world as well. So OMM is just the overall encompassing practice. OMT is osteopathic manipulative treatment. So that actually itself refers to the manual techniques that we do, the diagnostic changes we perceive, and then how we manipulate to address those changes in body structure to improve physiologic function. So Manipulation here, again, the therapeutic application of manual pressure or force. So we spend like a good hour in my own when I was in medical school learning about the history and sort of just making sure we're able to like discuss it with MDs. So hopefully try to keep this brief as well. So our founder, A.T. Still, also known as Andrew Taylor Still, hopefully an endorsement of our field where he lived to be 89 years old at a time where in 1917, you know, even without World War I, the life expectancy was like 48 to 50 years old. He was the son of a physician and a Methodist preacher. And typically at this time, it was common practice that instead of like a common medical school that you learned under another physician. So he was essentially taught by his father, who a Methodist preacher is, you're a traveling doctor because you go from Indian reservation to church to preach the word of God. And so he was sort of like a traveling physician by trade. So what we consider like a family doctor at this time. So during the Civil War, applied at working as like a hospital steward, using resources within the hospital, and with enough time becoming a military physician and a surgeon. So during the Civil War, he talks extensively about like the impact that the death of his children had. So there's accounts that say that like basically 4 of his children died within the course of 4 weeks. So 3 of his children died from spinal meningitis, and his 4th child died from pneumonia. And his first wife died actually like 5 years before because of birthing complications. And so he said a lot of this made him really disillusioned with the healthcare practices of the time, and especially with the use of medications at that time, trying to develop a different process. So a lot of self-education. A lot of the practice at this time was learning anatomy, which involves like the exhuming of like cadavers and corpses and learning anatomy really well. So about a decade later, developed his ideas for what osteopathic philosophy was and opened up his first clinic. And this time he was known as someone where nowadays we think about like thrusts and adjustments and manipulation. And he was something of like a lightning bone setter, was a word that we see used very often. And he was known for not using the medications at this time. And as I mentioned, in 1885, it was either his son or his family who coined the term osteopathy to say, oh, it's the disease process coming from the bone. And like, well, there's like muscles, heart, tissues, everything is collaborated, but I'm accepting of this phrase for the healthcare field. Briefly, I'd like to talk here about how we mentioned he's able to manipulate without and to treat and heal people without using any drugs. And I like to probably briefly point out that the drugs at this time, we were talking about calomel, which is mercury, and these are usually purgatives that either act as laxatives or emetics at the time. Tartar emetics, antimony, whiskey, opium, and bloodletting. And typically when you think of bloodletting, it was done not by like traditional surgeons, but by barbers, because barbers had a separate role back in the time too. So definitely if you have a good chance to take a look at like medications from the 19th century and seeing how a lot of things have changed from that time. So, okay, let's see. All right. Oh, sorry. I was trying to read through the chat to make sure, and I saw the notification. Sometimes as a non-DO, it's hard to explicitly differentiate OMM from chiropractic medicine for patients. Would love any thoughts you have. Oh, that's excellent. Yeah. So I'm going to go into that. So thank you for bringing that tip. Yeah. So growth here. In 1892, so again, like 1876, he sort of developed his school. So in 1892, the first school of osteopathy was established. Here you have like 16 women and 5 women. There is some mention in the books that there's something about his method of beliefs that said like you can accommodate for all races and creeds to really go into the practice osteopathy. He sold himself as not really blocking off people from entering into the school. Most of which are still his children and one of his brother. So to hopefully answer for some celebrity information here, I don't know if I could see like my the skeleton in the center, but just to the left of it is a surgeon by the name of William Smith, who was taught in Edinburgh by a surgeon who was so good at deducting and observing people that he was the inspiration for Sherlock Holmes. And so that's the guy just to the left of the skeleton. In the back row, to the very far left, the guy with the mustache, that's Struthers, and he was a friend of D.D. Palmer and who taught him osteopathic principles. And D.D. Palmer, if you look into names, is the founder of chiropractic medicine. And so like it's saying that chiropractic and the practice of it sort of came out around the same time. He wrote maybe like a decade and a half after AT stills. And so a lot of the ideas like, they deal with like bone manipulation and adjustments of the spine for the alignment. Whereas like with osteopathic principles, we do learn those thrusts and adjustments, but what we typically like to specialize into is the palpation of like soft tissue. And so applying like direct techniques and not relying entirely on thrusts. And then we'll go a little bit more into that later on as well. So the American School of Osteopathy eventually became the Kirksville College of Osteopathic Medicine, which we call AT Still University today. Briefly into like the 20th century, one state, Missouri, where we started legalizes osteopathic medicine as a profession. 1951, the US Congress recognizes osteopathic physicians. And then by 1973, the DO degree is recognized in all 50 states. So Spanish flu was like a big point of for education for osteopathy or for selling it, because it mentions that when you think of like the mortality rates around the world, it's about 21 million people, or like 1% of the actual global population. With the US, 36% of people within the military hospitals are 30 to 40% within a medical hospital. And so a lot of this, again, is like word of mouth, is just from like self-reporting and surveys. But they mentioned that even with like the Kirksville College of the Osteopathic Medicine and the physicians at that time, they reported on about 100,000 patients, give or take, and their mortality rate ended up around 0.25%. So I wanted to hopefully see if for some small audience participation here, if you know, the AMA basically recommended supportive care from a medical standpoint for a dose of aspirin. Could you guys just either send it a chat or just verbally guess like the dose of aspirin that they recommended for treatment at this time? Sorry, I can't find the chat. Okay. I think that's okay. I think that's, yeah. So I'll read here that, like, basically the dose of aspirin they recommended was a dose of 1 gram every 3 hours was what they considered like a supportive dose at that time, which of course compared to our 81 milligrams as well. So, yeah. So today, 40 accredited colleges of osteopathic medicine in the US, 25% of all US medical students are DOs, and usually that representation is 50% men, 50% women, but actually a little bit more women in that distribution as well. Combining medical students and just practicing DOs, that's about 178,000 people. And then previously, our residencies were AOA accredited, and sometimes dual credited with the ACGME, but as of like 2015 to 2020, we went through a merging system. So now we have single accreditation through the ACGME, though you can have ACGME accreditation with an osteopathic recognition designation, basically meeting criteria that you are implementing the core philosophies that I will discuss later on as well. There's some flexibility here for residencies. I know friends who will go entirely into a 3-year, a 2-year osteopathic manipulative medicine residency with neuromusculoskeletal medicine. So they'll be seen as an OMM and MM resident. First year usually in family medicine and 2 years of pure osteopathic practice. It's also offered in many cases as like a single year fellowship too, so that you could finish an internal medicine residency or family medicine residency and then proceed for an extra year for osteopathic board certification as well. So up here in the top left is like a common, this is like a common finding that we have where when I was in medical school, it was 1 hour of a didactic lecture and later on 2 hours of OMM labs on top of like clinical practice labs. And that was usually like 3 hours every week that we would incorporate for our practice. And as you might recognize, there are many DOs and how we implement OMT is very personalized. There are people who will never use it ever again. There are some people who still find limited use combination medication and OMT, and there are some people who just purely practice nothing but as well. Yeah. So I wanted to move over here into osteopathic philosophy, and so these are in color a lot of the tenets that we hold, that we are taught and are expected to remember. So I'll go individually through all of them. Like the first one is a person is a unit of body, mind, spirit, meaning that no single part of the body functions independently. Each part is interconnected with all but others and serve to benefit the collective whole of a person. And so even alterations to any single part of the triune, mental and spiritual health affect the body, and then the body affects the spiritual and combine together. So I want to note here too that AT still in the development of his philosophy, he spent several years with like a Shawnee Indian reservation up in the Midwest area. And so there's concepts of like spiritualism that comes from Christian beliefs into like Native American spiritualism and healing that sort of like affect like this idea as well. The second one, the body is capable of self-regulation, self-healing, and self-maintenance. So complex homeostatic mechanisms exist for the body to heal itself from injury. Dysfunctions often arise during this compensatory process, and osteopathic physicians adjust the body to realign these parts back to normal. Again, saying that like when your structure is properly aligned, health should be the natural state of the body, and that you're capable of like promoting into your own health. Last one, structure and function. Sorry, not the last one. The third one, structure and function are reciprocally interrelated. Structure governs function. AT still says like you're able to look at a bone and see anatomically the way that it was formed is designated to provide function, like the like the ball socket component of your shoulders, the muscles, everything is meant to with a purpose in mind. And so conversely, abnormal structure means dysfunction, and with dysfunction is reduced capacity for self-healing. So the last principle truly is that with all the three others before in mind, rational therapy is based upon an understanding of body unity, self-regulatory mechanisms, and the interrelationship of structure and function. So basically saying that the three principles from before, the unity, body, mind, spirit, self-healing property, structure and function, a proper treatment of a human body requires a combination of all these concepts united as well. Another idea that we applied, this is basically the models of treatment, where most of the time in the 5 models, we try to incorporate either 1 to 2 or 3 of these ideas at a time whenever you're trying to treat for someone. So we have the biomechanical model, respiratory, circulatory, the neurological model, the metabolic energy model, and then the behavioral model. So in these 5 models, of course, like the biomechanical, you're talking about somatic dysfunction, inefficient posture, joint motion restrictions, and basically when you're seeing problems here, alleviating it with OMT to restore motion and function. From the respiratory circulatory, you think of like vascular compromise, edema, tissue congestion, poor gas exchange. And here using mechanical impediments to respiration, circulation, trying to relieve congestion and edema. So usually lymphatic and venous drainage techniques fall into this area too. With neurological techniques, basically abnormal sensation imbalance of your autonomic functions, and then central and peripheral sensitization, nerve pain. So trying to restore normal sensation, and also like neurological processes and control. A lot of overlap here with chiropractic thought as well. And metabolic energy, usually thinking endocrine, and from an endocrinology standpoint, there's energy loss, fatigue, ineffective metabolic processes, and toxic waste buildup, and poor nutrition. And so basically trying to restore these metabolic processes and alleviate inflammation, infection. And then the behavioral too. So this like the mind, the spirit component. So making sure that like reducing poor lifestyle choices, people getting demoralized from significant hospitalizations. And then this one, like assessing and treating like the whole person as well. So actually here, in the biomechanical, I mentioned somatic dysfunction. So as we move towards into like palpation and physical assessment, it is a very important concept. So any person who, even no matter where you are as a DO, no longer practicing bio to starting, somatic dysfunction is typically like the one word that we remember. And it's the one that I still use to this day, where it's like, oh, like I know what this is and I don't talk to people a lot about it. So basically I mentioned the 5 models for like how we typically approach people. Like it's just sort of mapping out like the body from different approaches that you can take, you know, neurological, biomechanical. So somatic dysfunction at its most verbose form is the impaired or altered function of the related components of the somatic body. That's your skeletal, arthrodeal, myofascial structures, vascular lymphatic. So basically naming those 5 models of our approach. So saying that any altered function in that area, um, and again, if we remember, function and structure are correlated. So like seeing altered structure, altered function, all constitutes somatic dysfunction. And typically somatic dysfunctions, we identify them as things that are treatable through osteopathic manipulative treatment too. The older adult, so here, uh, again, when you think of like younger people, we say that like the body has self-healing mechanisms, but with age too, it's harder to maintain structure. So aging affecting the biomechanics of the neuromuscular system and lowering your ability to withstand stress, your physiologic reserve coming down. So chronic diseases, injuries, and then with like ergonomic posture changes, these things that you're able to handle with some aplomb in your younger age. As you get older, these stressors compound on top of each other and they become exceedingly more difficult to remove off. So then the body's ability to self-regulate and heal in the older patient is a lot more impaired than typical. And so the treatment goal is, with this knowledge that while we are trying to restore function, that not all the systems we can say are going to be completely irreversible from that standpoint as well. So again, some of the common pathological changes that we see in older adults is, if you've come and seen, like we call it like a hyperkyphosis presentation, the Dowager's hump. So some of the things that we see with this too, for example, is that basically because of either a cause from a vertebral body fracture, low bone density, degenerative disc diseases, you have like a wedge fracture, you're more prone in your upper vertebra to sort of collapse and push you anteriorly forward. So if you look at this older adult's thoracic spine, that causes an increased curve. And because of that, you're sort of forcing your head to like look down. And so some people are able to compensate by contracting the neck, because now if you're looking down, you have to basically move your eyes to look forward, or you have to extend your head to look and to keep a level field. But that increases the kyphosis and then the curve of your neck, and that can cause postural instability. Simultaneously, if they're not able to compensate, then your body tries through other mechanisms as well. Either you can stiffen your lower leg muscles to lean back to help compensate for this instability. But again, with age too, considering that you're losing muscle mass and strength from place to place, increased frailty. So these compensatory mechanisms that your body typically has in place for these chronic changes over time might decompensate as well. So, and then a few other things here: vision and hearing problems, vestibular dysfunction with less input from the inner ear, so increased dizziness and vertigo. We think about like proprioceptive loss. Because of your head coming down, you're not able to really visualize where you're going as well. Recognizing where your knees, feet, and hips are so you can connect with like your visual function. Combined on top of other things like peripheral vascular disease and venous stasis dermatitis as well. Posture imbalance and gait instability. Leg discrepancy comes up very often. You think after like a hip or knee replacement, one leg ends up being shorter than the other leg. And this small adjustment is something that in an older person, that now the body has to compensate more acutely, and that can cause increased falls in a lot of people as well. And then of course, having these things worsening your depression too. So like the fear of falling, that perception of like less stability and reduced mobility. So being demoralized from this standpoint as well. Um, so later on, we'd like to talk about like, there are things that in the MD world where it's like there's medications, physical therapy, there is external factors, internal factors, and then working with social work to help address the body, mind, spirit, this component. But what I try to submit to is that by adding somatic dysfunctions, now we can also like treat with like OMT as well as like a separate entity. So physical exam, we'll do like a postural examination, so making sure that the body and spine is like level from the field. I'll move into some of these slides to show you. So sometimes we can take a look at someone's gait, seeing how they're compensating from one leg to the other. This is typical in an osteopathic exam, and also checking for symmetry, asymmetry as well. Postural positions, what I like to do is having someone stand up straight. We make them look to the side. You can draw a plumb line down and basically follow the curve of a neck down to the curve of the thorax to the curve of like the lumbars as well. And basically, if you see the inflection point in the vertebral column, that's supposed to come up to like L2, and so the very front of like L2. And so this is where I think like hopefully the meat and potatoes for like my presentation is like trying to relearn palpation again. A lot from my standpoint is remembering anatomy and using meaningful touch, but for us trying to relearn how to use like our finger pads. So I like to remind that like, we trust like our own instincts and our own physical exam. Our fingers are some of the most sensitive nerves we have in our bodies, especially because 2-point discrimination, the fat area, we're able to like discriminate between small changes in between people as well. When I first started out, it really much felt like you were putting yourself bare feet into like a swamp and that you really didn't know what you were stepping on. And over time, I think with that metaphor, it comes to a point where it's like, okay, I know I'm stepping on rocks, I'm stepping on a fish, I'm on a frog, that's like dirt. And then being able to have like a stronger sense of where you're placing your palpation. So when I have my fingers on someone, what I liked, if you guys can also join in, you don't have to. I'm fine without to. Is that I look at my forearm, and one of the first things we teach is that like you recognize from the skin level going down to the bone level, and being able to appreciate that difference. So like when I'm palpating, for example, like if I have my hands slightly on my skin, and I'm just moving left to right to move skin alone, but not muscle, and then recognizing that's at the skin level. um, in your mind, you can think like, yeah, there's subcutaneous tissue, there's vessels, sometimes you could feel that, but it's not as important. And if you press lower, you can try to feel fascia. Fascia is the connective tissue we're basically talking about. It's right on top of muscle. So just before you're about to move muscle, that's usually smooth and firm and is usually like able to be easily glossed through as well. And then once you push down further, you're getting to like muscle length, and muscles, if you're going across section, you can feel like striations, and that's like the deeper area down to like bone, and basically feeling like contours, landmark structure, and symmetry from that standpoint. Well, something, the first of the treatments I will be teaching implements the ability to like look into muscle. So back to somatic dysfunction, the ways that we typically identify somatic dysfunction is with a concept that we call TART or STAR. TART is a more common one, so I'll talk about this. Hopefully these are things that when you're looking at someone's back, you're able to identify even without having to use complex terminology for it too. So we always say TART, so versus tenderness, being able to elicit pain with touch. Asymmetry, noticing that someone is rotated one location, that you're side bent in another location. On the back, we commonly use side bent left, rotated right, or side bent right, rotated right as like a common diagnostic feature of somatic dysfunction. A range of motion, that we basically rotate someone to the left or to the right and see where that restriction is. And then tissue texture changes. So when I say tissue texture changes, there are acute changes and chronic changes. So acutely, you think of like an injury, like a fall. In that situation, you're thinking boggy tissue. It's sort of like swelling is there. It's warm, it's red, it's hot. And then the chronic changes that you see are usually ropey muscles because of over time chronicity makes it that like it's usually cool to the touch. It feels like muscle fibers in the back are closer to like strings or cords from that standpoint too. So this is very common because in an osteopathic approach, people will come to you and say like, I have back pain, I have thoracic back pain. Usually the reason why we go from like a head down to the spine is that we're trying to make sure that there are anatomical findings you can find in the lower part of the spine that can cause referred pain or because of decompensation mechanisms contribute to discomfort in the rest of the patient, which is why for us, you should try to do a comprehensive exam because there are areas of diagnosis that are contributing to the overall health of the patient, not just for pain, like a local or specific area as well. And so in the elderly patient, these chronic changes are really important. They're honestly like very common in every person. These are the things that cause compensatory mechanisms and contributes to like a loss of function. And so being able to identify them is very helpful for having an idea for how to approach treatment from there on out as well. So for example, think of like, you know, we say acute on chronic kidney disease. We also say the same for like TART, for like acute and chronic changes too, because you can have chronic changes on a patient. You think of someone from Med G who has either a fall or a motor vehicle accident, and so they will come in for the acute changes, acute TART changes, the boggy edematous tissue of increased muscle tone. But then as you look over across the rest of their body, they will have chronic changes as well. So you have acute on chronic TART changes or somatic dysfunction. So I wanted to go into some techniques. There are many techniques. There are many schools of thoughts. We have ideas where it's like, oh, there's a New England way to do this technique. There is a California way. There's a Texas way. Everyone has developed their own school. But ultimately, you can generally split them into like an indirect and direct profile. So if you look at my skull here, there's front to back. The exercise I like to think about here is that you're like basically turning your head left and you're turning head to the right. When you turn your head to the left, that's active range of motion. And once you reach a certain barrier, we call that the physiological barrier. Your soft tissues there basically restrict you from moving any further. And if you push passively, that's basically us trying to move you into the anatomical barrier. The anatomical barrier is basically the restriction set at the final limit of motion. And that's usually like where your bone hinges prevent you from going any further. It's like literally your vertebra is like a door hinge. You can't go any further than that. And when you do, that tends to incur injury for people as well. So if you look here, when we think about like somatic dysfunction, we also think that like basically you reach a pathological or a restriction barrier, meaning that like I'm turning my head to the left, I'm turning my head right. And then I'm feeling right here that I cannot turn my head completely to the left. And that area is what we call like a restricted barrier. And so our techniques that we use typically are either direct, meaning that you move into the barrier, trying to force it so that you reach your physiological barrier, or indirect treatments, which is basically you're moving away from the restriction. And those techniques sort of putting you in the area of freedom where you're more easily able to move. There, I mentioned a handful of names that you're seeing: counterstrain, myofascial. Yeah. So, yeah. So the other one is the more direct techniques we'll talk about, which is high velocity, low amplitude techniques, muscle energy, which I will teach a little bit, and then articulatory techniques, which is like situation. They're mostly just pulsing into the restricted barrier. So for anyone who's ever watched a YouTube video of people doing like neck cracks, back cracks, and all those fun little noises, and we say in DO schools like crack addicts, HVLA is what you typically know chiropractors for. So that's when you're hearing like, oh, chiropractors, you're basically working with like neck adjustments, back adjustments. And if you look again at the barrier for the red, the pathological restriction barrier, it's high velocity, so you're moving really quickly, but it's low amplitude, meaning like you're not like trying to extend past the anatomic barrier. So that's like the idea for that technique. And so hopefully to answer your question, Tiff, chiropractors tend to focus primarily on HVLA as like the form of techniques that you're seeing the cracks and the adjustments. And I think for osteopathic physicians, we do know how to do it, but typically we like to facilitate a lot of soft tissue techniques and use like a lot of the other techniques that I sort of had listed as well. A reason why I have a slide mentioned for this is that we have a lot of contraindications, especially for trying to avoid using it in like acutely injured patients. But like as a rule of thumb, we don't usually use it for older adults, especially because if I'm seeing you in a clinic for a first time, it's like, and you don't have blood tests and you're like, I don't know what's your level of osteoporosis. We again try not to break your anatomic barrier, but again, like any prior histories of like fractures makes me reticent from wanting to use it. So again, like these high thrusting, high velocity techniques in the elderly, I would avoid. However, age is not absolute contraindication. There are some people who are comfortable to work with like a 65 or 70-year-old who has good functional age, where we might be comfortable doing it if you think that's appropriate in that situation. And appropriate is a matter of like user interface and a little bit of like us deciding how comfortable we are. The tricky thing here is that even gentler techniques, if we're not careful with in the hands of a practitioner who's not very conscientious, you can cause post-muscle treatment soreness as well. Yeah, quickly reading case statement here. Yeah, chiro foundation is with spinal readjustment, yep, versus osteopathic treatment, which is that the whole musculoskeletal system, the bones, the joints, the tendons, the fascia are out of alignment. Thus, you need to address it all versus just simply addressing bones. However, chiro does use a lot of non-other HVLA techniques using other CAM therapies like acupuncture. Yeah. So thank you, Kay. Yeah, that was a great summary of like the how to delineate one. So shortly, like chiropractic, you work primarily with bones adjustments, and then with OMM, like working within all these other anatomical areas as well. So a common form of the somatic dysfunction that I like to talk about and hopefully help for teaching is we talk about myofascial pain. So this is like discrete nociceptive pain that's within a muscle. This can be acute or chronic, usually caused by microtrauma. And so this sort of pain is different from a fibromyalgia pain. And so this is what I'm talking about. Whereas like from our standpoint, anatomically, you're looking at someone and even with like your muscle structures, you're thinking of like your formal like and classic doctor differential diagnosis. But here we can add on a perception where you can perceive like muscle tone. So the cause of this is shortly for me saying like you're basically essentially living life. So like overuse is like repetitive motions. Microtraumas can be caused by like lifting boxes over a certain amount of times, like your Amazon worker, holding a phone under your chin, sleep postures. You can also have it with the classic like computer posture where you're like looking forward. So like you have increased lordosis of your spine as well. Inappropriate stresses, again, like with surgeries causing leg length discrepancies, local irritation from like falling on your joints as well. And like other acute issues like surgery or scars can also cause myofascial pain as well. So here to talk briefly, like when you have myofascial pain and you have it multiple areas of it, we would call it the myofascial pain syndrome. And here trying to make sure that like its symptoms are connected to osteoarthritis, bursitis, fibromyalgia syndrome, other musculoskeletal diseases that overlap, but simultaneously it's like its own identity. And this is pretty big for like geriatric patients where it's like you can recognize the other circles, but now you have like the ability to assess for like these trigger points that gives you like an extra edge for like diagnosis. So majority of chronic patients will have this, and the majority of older adults with chronic low back pain will have a myofascial pain syndrome. If you have like a knot in your back, that is essentially, think of how common that is. And then in 30% of patients presenting with pain. So so findings here, this is like a trigger point that you can find on someone. So if you remember, we were talking about like you start your palpation from the skin, you're moving down to the fascia, you're going down to the muscle level, being able to say like, okay, that's not coming from within the bone, it's not coming from within behind the ribs and the organs, it's coming from like a muscle. That can help you identify quickly like an area that you can quickly treat. So a trigger point is, if you see here, like a irritable spot in your skeletal muscle. It's a nodule you can typically feel that's painful either by itself or with palpation. In there too, with that nodule, moving towards the origin, the assertions are taut bands. So basically tense muscle fibers because of those nodules. So you follow along the lines, you can feel for that as well. And basically they extend from the trigger point to the muscle attachments. So let's see. So where we typically practice from the fundamentals and where I hopefully see that if you could practice too, I know that we're all separate and that usually I would ask someone to find like a partner or someone you can work on, but this is very easy to do. You can just find like a family member if you want, or like a friend, give them like a back massage, but now you have like OMM palpation in your mind. You're basically trying to find these three that helps you confirm like a palpatory diagnosis. You're not at the bone, you're pressing down, you're not the bone, you're not the skin, you're trying to aim for muscles, trying to feel the striation of the muscles in your arm. You're finding a tender point within a very taut band of muscle, as we saw before. And then the patient's able to recognize pain with palpation as well. And sometimes these areas are so intense and they're so irritated and that they're so inflamed that they might trigger like a twitch response or like a little spasm. And there you're able to sort of confirm like, okay, this is like a trigger point. I'm in a muscle, it's responding. Also think of like your TART changes too. This area can be like red or hot or acute or ropey, depending on like how you're looking for it too. Hopefully won't talk about the etiology for like referred pain, but it's very common again that if you have like a trigger point that's in one area of your neck, because it affects like the dorsal horn and then the nerve findings in that local area, other sites can experience pain, even though when you're touching it physically, you can recognize that there is a nodule at like the back, which is why it's important that when people complain about pain in one part of the body, you're still doing a top to down exam to say like, well, that could be caused by like a trigger point, that taut nodule in a separate part of the body. So, so manipulation here, this treatment style, what I would say, I'll sort of give you an example. So I had a patient who was admitted for a fall. She didn't break anything, but she fell on her left shoulder and she had vestibular dysfunction. So she was sent to Park West, our skilled nursing facility, for vestibular rehabilitation. So when I saw her, she's like, well, like I'm waiting for PT and can you give me ibuprofen because like my left shoulder is hurting a lot, you know? And so in my exam, like you can do like shoulder range of motion. It's limited because she had prior injuries there, but also like palpating in the lateral deltoid, you could feel for like a taut muscle band, very painful, and sort of like the pain symptoms she mentioned was going across her entire shoulder. So almost like referred pain from that standpoint too. So what I do here, and this is very easy to do, you basically have one finger on the area where that nodule is. You don't have to press hard, you just place your hand there. And then you position it in such a way that reduces tenderness. So this is by shortening the muscle, the surrounding tissue. So my example here is that if you have your arm, the natural motion is to go up, that's your abduction. And so my abduction is at the deltoids, you're trying to shorten those muscles. So you basically passively put someone's hand here. The important thing in this procedure or this manipulation is that your arms should be comfortable. The patient should not be contracting and you should not be tensing up. You can prop yourself up either like on a table or on your knee to hold yourself up. So basically monitor, passively shorten the muscle that you're working at, and you hold for about 90 seconds. After that time, tell them don't contract. You put down the arm again, and that area, basically the muscles should reduce that tenderness or reduce that muscle band there. So that's why I recommend starting at the shoulders, because it's such like a big muscle. It's easy to find these tight muscle bands that you can appreciate. But more advanced techniques for like osteopathic physicians, for example, is that you could do it for the piriformis. And you're like, I'm smart. I'm well versed enough in anatomy to know that I should be externally rotating you, flexing you, and abducting you too. So the technique you're seeing here for the legs and showing you where the structure is, it's like the more difficult or advanced form, but I think it's easy to say, like, if you're working from someone's back or shoulder, that you can extend them to sort of shorten the muscles. You can put your shoulder blades together as you're pushing in to sort of shorten that muscle band to get that response. So this is actually an indirect technique. You're moving into the freedom, again, the area of less of restrictions. We call this like an indirect technique. Yeah. And hopefully for this, it's a palpable idea. Like alternatively, the other way that you can treat it if it's still persisting is to do a trigger point injection. But again, looking here, you're confirming a nodule location, you're maintaining downward pressure to appreciate in between where the trigger point is, and you're inserting a needle between and away from the examiner. So if that's why I have a lot of faith that for MDs, this is like a very approachable subject. If you can do a shoulder or a knee injection, finding on muscle band and finding a little trigger point is a very easy thing to apply. It's very easy to learn to practice as well. Let's see. Also, okay, for K, also noticeable that myofascial pain can radiate, not necessarily needed, but can mimic neuropathic pain. Yeah, exactly, due to radiation. And then noted trust and participation, and then being relaxed is super important. So what sometimes I do, because you're waiting for 90 seconds with a person too, is that if I'm sitting down, I'll try to ask them, like this patient, for example, she was like a teacher. So, and she used to tell jokes, like, tell me a joke, and then trying to make sure you don't laugh too much. And then that's able to fill up like the 90 seconds before you have it come down. But again, it's very important to emphasize that both people must be relaxed for like the innate mechanisms of how counterstrain works to sort of go into practice as well. This one is myofascial soft tissue techniques. This is like what a lot of people see as like an overlap with like massaging in patients. And for me, this is like the osteopathic approach is saying, like, I'm appreciating anatomy in a way where I'm applying a stretch with the intention of like my finger is not at the skin. My fingers are at like the muscle layer. So you're pressing down to exert that pressure only to the muscles and not any further before applying traction. And so very commonly, I have patients who come in where if I'm thinking that they have like a tension headache, this is really easy to treat. This because especially like they're saying, oh, it's bilateral front band. I have a lot of neck pain, and there's someone who's very leaning forward. So being able to like have them relax their head into your hand. My fingers are doing motions of basically pushing into muscle, going past skin to muscle to the middle part of the muscle before pulling back and applying that. And usually this is like for 30 or 15 seconds. So the muscle bands, if you're looking here, they're vertical. So you can either apply a linear stretch going along muscle band, or you can do a perpendicular stretch, which is going across it as well. Muscle energy technique. I mentioned this before up. This is not good in older adults who have very weak muscles, because it requires engagement at that end. But if someone's able to walk into your clinic, this could be very useful as well. So basically, I'll use this example from up here with like the head. So imagine for me that I can move my head freely in this direction, and then, but for here, I'm sort of stuck. I cannot move it to the left. I can side bend to the right, but not to the left. So if this area is stuck, basically direct, I'm trying to go into the restriction. So applying a soft pressure into that direction, and basically you would ask like a patient to contract in the opposite direction of your hand. So you're pulling them into the area that's tight very gently. You're asking someone to contract so that you're going opposite of where my hand is. And you would say something like you're using a pound of force or ounces and not pounds, because you're not trying to overwhelm the hand. You're just trying to activate like the opposing muscle structure. So it's putting into the restriction, ask me to contract, relax, push, contract, relax, push, contract, relax. And then a little bit of like a passive motion too. This is pretty gentle, and even though it's a direct technique, it's one that's pretty well tolerated depending on which area of the body you're doing it. So in the same thing you saw before with like counter strain or like the folding of the muscle, you can, there's techniques, but there's also just knowing, like, I know what this muscle does. It rotates, it side bends, you flex or you extend. And so like, you just try to move into the barrier from that standpoint. Yeah. this I will try not to go into too much detail. We have a number of techniques that are basically pointed into your viscera. So the anatomy here, what I'm basically trying to say is that a lot of our treatment of the spine is based upon the idea that your spinal cord on the left side, you go to your sympathetic chain ganglion, and this is near your vertebral bodies, like they're like to the left or right of your bodies before they go to your end organ, which is on the right side. So usually it's treating for the things in the thoracic spine, your T1 to your T12, your L1, your L2. If you're seeing the green lines, this is basically areas that go to like a sympathetic nerve that before it goes to your eyes, your lungs, your heart, your liver, stomach, et cetera, et cetera. Parasympathetic innervation, if you're seeing the blue lines here, they're going from the cranial nerves, usually like C3 area, C2, C3 location, and the sacrum as well. And so that's where sympathetics are. So there's a lot of treatments that are like based on, if organs are having problems like stomach indigestion or pneumonias, you can sort of treat in the thoracic spine at the specific area of that problem. So like lungs, for example, would be like, oh, I'm going to look at T1 to T8 to treat. So hopefully that wasn't too confusing. So visceral techniques, I put up the circle here to remind us like the biomechanical model, whereas like we were doing a lot of the gray, the biomechanical, but you have also respiratory, neurological to work on as well. So you'll hear these techniques that when you refer to an osteopathic position, you're thinking like rib raising, mesenteric release to help relieve constipation, lymphatic treatments to help like reduce for infection infection as well. So as you noticed, the benefit of these techniques that you can do a lot of them like laying supine, and that's really helpful because like a lot of times, again, some of these techniques, you have to be conscientious of what an older adult can do. A lot of people are either wheelchair bound, they're so flexed that you're not really able to get into a chair to do the same techniques that a younger person can do. So this is really a matter of like user experience, and for me knowing what treatments I could apply for someone if they're in a wheelchair, if they have a sacral ulcer, if they have specific contractions or a cognitive impairment where they can't really follow instructions as well. And so I try to keep that in mind. Sometimes with like patients who do have dementia, who have like a focal point, having something, a nice little conversation, distracting them for a little bit can sometimes be helpful in that situation. So, so again, one to refer to an osteopathic physician. So sometimes if you have someone who has like pain and you're ordering an MRI, you've ordered like your neuroscience, you're like, okay, wow, like there wasn't anything on the MRI. I'm sort of confused. And to me, I'm thinking like, wow, that's really reassuring, because if you can't find something at the strong like imaging level, there's probably something at the muscle level you can very easily treat. And so like, again, like those trigger points are not things that you typically find from like imaging, they're things that you discover through like palpation as well. So like, so again, on osteopathic treatment, you think of like a musculoskeletal pain for a number, once all these other etiologies have been excluded. So low back pain, once you don't think the infection, malignancy, or other things like kidney stones are contributing, then like that's a reasonable area to help them see an osteopathic physician. If you're worried about falls, again, from our own teaching, there's medications to reduce, there's external factors, putting up a ramp, but trying to find a somatic dysfunction, I think, is its own separate entity that you can treat and say like there are small adjustments you can make either those trigger points that can relieve pain for like a lot of people as well. So here, like, find a DO for the osteopathic, and you can find not only just for like those who practice OMM or OMT, but people like surgeons, like just other DOs in general too. And then the American Academy of Osteopathy, also a similar one, find a DO within like your relative zip code as well. So closing up and hopefully on time here. This is one of my favorite quotes, and one commonly said by A.T. Stills: to find health should be the object of a doctor, and anyone can find disease. So I think especially for me, I grew up when I went to medical school, when I was applying for medical school, because I was trying to go into geriatrics. I thought that the DO philosophy very much overlaps with a lot of concepts that I think are helpful for treating the geriatric patient. So of course, there are some things that are exclusive that you wouldn't see in geriatrics with an osteopathic approach. Like we have people who specialize in pediatrics, obstetrics care, people who are in surgeries who are very good at like post-operative management as well. this 5 model approach is a little different and OMT specific to us, as opposed to like some of the other things that are more traditional within the geriatric field. But here in this like nice, juicy purple grapey overlap, I see like individualized functional assessment, recognizing that like every person is different. You have your own body, and the human body is more or less the same, but like how you compensate for your function is different from each person. And so like the things that work for one person might not work for another person. So even OMT, the simpler techniques you can use in every situation, but some people cannot be like optimized for that, and we sort of adjust for that as well. So seeing that there's a great overlap for like falls prevention, managing symptoms by finding those specific trigger points or those restrictions and moving within them. And when you're addressing pain from a different perspective, addressing polypharmacy and sort of finding health. So again, I sort of listed here before the core philosophies with rational therapy of all other 3 tenets: the self-healing, body, mind, spirit, the structure and function connection, and seeing where it overlaps with like the 4 M's too. So I think for finding what matters, I think Kay, previously you had like patient priorities care, saying like when you have so many comorbidities going on, what is a thing that you want to do? You know, like is that like walking a certain distance or moving a certain way, just falling less or being less afraid, and being able to like meet that goal using like osteopathic medicine or an osteopathic approach. Medications using only what's necessary and doesn't interfere with other M's. You know, osteopathy having another mean to like control pain and to find these dysfunctions to help the body compensate and perform better functionally. Mentation to reduce addressing the psychological distress, better pain identification, reducing delirium and depression. There are people who are in the hospital where if they have pain and they're not able to report that pain, that I found that like an osteopathic exam, very briefly, you can find points where someone's wincing and that you could still recognize those symptoms and treat for it focally too, either like again, stretching, working with rib raising, or just like treating like a trigger point or something like that as well, that you can do without someone reporting it. And in mobility, of course, increasing a person's range of motion and better tolerance of their ADLs and IADLs and safe movement. So, and then multi-complexity, again, with the person being body, mind, spirit, treating the whole person and not the disease. So a summary, these are hopefully the things that I wanted to like teach for you. Geriatrics and osteopathies share principles that focus on the individual, not the disease, as I mentioned in the previous slides. There are fundamentals of palpation that I was talking about. The TART changes tenderness, asymmetry, your range of motion, tissue texture changes, that you, not being an osteopath, you can find that, and you can find further sources of pain and impairment within your patients, that these somatic dysfunctions are another level of addressing structural problems and discomfort that a patient might not have addressed elsewhere. There are many techniques. Some take years to develop and to understand, that only some people require decades. But I think that more importantly, some of the things that I sort of introduced here, you can really use quickly. The counter strain, just finding like a muscle band, doing a light stretch in the area, understanding like how to go direct and indirect techniques, you can do them very quickly and produce like a huge impact on some patients, very without a problem. So again, at the bottom, somatic dysfunction treatment, you can help regain the function and a better quality of life. Of course, in the older adult, the functional decline is irreversible with these stacking changes, but hopefully osteopathy, manipulative medicine treatments help you find structural problems and help maintain function for an amount of time to help older adults do what they want to do. These are some podcasts. I actually don't know the right one, but I thought it was really cute because that was the logo they had, the DO or DO not, but the Rolling Bones Osteopathic podcast is a good one. I recommend to medical students to follow along, like people who sort of apply it into like practice, main person being like a family medicine doctor, you don't want purely osteopathic treatment too. And yeah, that's my thing. Another final quote from AT Stills: find it, fix it, and leave it alone. Yeah, so 9 a.m. Sorry for running short. I'm happy I got to get through in time, but are there any questions?
Thanks so much, Chris.
Mhm.
Since we're at 9 o'clock, we can maybe take a 1 or 2 questions, if folks can stay on. I think you might have answered all the questions already. You did it as you went. So thanks for doing that. And thanks for this fantastic talk. Have a
Yeah.
great weekend, everybody.
Mhm.